Good afternoon, Dr. Freer. Are you okay to get started?
I am.
All right. Good afternoon, everyone. Thank you so much for joining the Los Angeles County Department of Public Health today, March 10th, for a media briefing. Today, we have the Director of Public Health, Dr. Barbara Freer, presenting. Dr. Freer will then take your questions. Dr. Freer, when you're ready.
Yeah, thank you, and good afternoon, everyone. Welcome to today's briefing. I'm pleased to have an opportunity to share a status update and provide further information regarding our post-surge plan, as well as responding to your questions. Specifically, I'll be sharing our metrics on cases, hospitalizations, and deaths. I'll provide an update on our post-surge response, including our community-level indicators, early alert signals, and our preparedness efforts, with a focus there on vaccinations and therapeutics. I'll share an update on masking and isolation and quarantine requirements at schools. And finally, I'll close with a reminder for all of us to consider our personal risk and the risk of those around us when we're choosing which precautions to follow. I'll take the first slide. Last week, I reviewed the key components of our post-surge response plan, and today I'll provide updates on our indicators and related efforts. Under CDC's new risk methodology, LA County remains in the low community risk category this week. This is positive news as it signals that we're continuing to minimize strain on the healthcare system, which has always been one of our primary aims since the start of the pandemic. However, this level does not necessarily mean that we have low community transmission or that COVID-19 poses a low personal risk. Thus, while we're going to work to protect our healthcare system, we'll also continue to use community prevention strategies that can reduce risk for all of our residents, particularly those most vulnerable to harm. And we'll provide everyone with information so that they're able to make the best choices to protect themselves, family members, and our communities. With that in mind, I'm just going to share our past week's metrics. As you'll see, we have continued to see substantial drops in reported cases and hospitalizations. And this week, deaths have dropped slightly as well. Today, we're reporting 1,372 new cases. The average number of daily new cases reported over the past 7 days declined to about 1,100. This is from about 1,700 the prior 2 weeks. From March 3rd to March 10th, the 7-day cumulative case count decreased by about 5% a day. Our 7-day average daily case rate also declined to 11 new cases per 100,000 residents. The 7-day average daily test positivity rate also declined to slightly under 1%, which means that 1 out of about every 1,100 test results reported to us were positive, compared to about 1 out of every 4 near the beginning of the year. As noted, hospitalizations are a key component of CDC's community-level measures. In LA County, hospitalizations continue to decline, and today we're reporting 632 people currently hospitalized with COVID. And again, as you can see, a significant drop from last week. Unfortunately, daily deaths declined this week to an average of about 40 people passing away each day. That's from 55 people dying the prior 2 weeks a day. While this is encouraging, it's still disheartening that we're continuing to lose so many residents to COVID-19. And I am sending my condolences and wishes for healing to all of those who are mourning the loss of a loved one. Next slide. As we discussed last week, post-surge efforts are being guided by our post-surge response plan, which has 3 core components: the use of indicators that reflect risk, which are then tied to community prevention strategies; early alert signals that trigger a review of contributing factors and potential need for us to realign those prevention strategies; and a post-surge preparedness plan that will help us respond appropriately to signs of a possible surge or variant that might spread more easily, cause more severe illness, or evade vaccine protection. This week and in the upcoming weeks, I'll be sharing updates on each of these core components, starting first with our updated CDC community level and the indicators that comprise this measure. As a reminder, CDC updates this information once a week on Thursday, and it assigns risk levels based on a combination of 3 metrics. The first indicator is the case rate for the past 7 days. When determining the community level, CDC first uses this case rate to determine whether the county had fewer or greater than 200 new cases per 100,000 people in the past 7 days. As of today, LA County's case rate is 89 new cases per 100,000 people. The next two indicators are hospital metrics to serve as a proxy for the level of strain on the healthcare system. The first of these indicators is the 7-day cumulative rate for new COVID-19 hospital admissions, which today, as you can see, is 7.2 admissions per 100,000 people. This meets the CDC criteria for the low community risk level. The second of these indicators is the 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients. This is now 4.1% for LA County, which is also in the low level of risk. As we noted earlier, the designation as at a low community risk level doesn't mean that there's a low rate of community transmission or reflect personal risk. Rather, it signals that we've successfully reduced the pressure on the healthcare system. Next slide. This slide just shows graphically the progress on the two hospital indicators that CDC is using, daily admissions and the proportion of staff beds occupied by COVID patients. You can see that both continue to decline. As of March 8th, the 7-day average proportion of inpatient beds occupied by COVID positive patients declined by about 90% since the peak of the surge. And the same thing for the 7-day cumulative COVID hospital admission rate, also declined about 90% since its peak. Next slide. While it's important to assess the burden of severe illness and stress on our hospitals, we're also tracking a set of early alert signals that allows for us to have an early identification of issues that may indicate the need to realign strategies to slow spread or contain outbreaks. We're monitoring 7 early alert signals, which include 3 community-wide measures, variants of concern, emergency department COVID-19 visits, and the cumulative crude case rates in high poverty communities. The signals also include 4 sector-specific measures, which are new outbreaks at skilled nursing facilities, new outbreaks at TK through grade 12 school classrooms, new outbreaks at settings with persons experiencing homelessness, and clusters of cases at work sites. If we see 2 or more community-wide measures reach the threshold for moderate or high concern, we'll conduct a review of contributing factors and consider changes to our community prevention strategies. If any sector-specific alerts reach the threshold for moderate or high concern, we'll implement mitigation measures that are tailored to that particular setting. The latest results for our early alert signals are listed on this slide. As you can see, for this week, all metrics were considered to be of low concern, except for the number of new outbreaks at TK through grade 12 school classrooms. As was the case last week, this still meets the threshold for moderate concern, with 4 classroom outbreaks opened in the 7-day period of March 2nd through March 8th. Since we didn't review the data for most of our early alert signals last week, I'm going to briefly review each of these indicators today, but I'm going to start with the school outbreak metric, since as noted, it met the threshold for moderate concern. In future briefings, I'm only going to focus on early alert signals that meet the criteria for moderate or high concern. Next slide. This slide shows the outbreaks in TK through grade 12 schools and programs in the past 7 days, covers the time from the start of the school year through March 5th. Of note, whereas our school outbreaks metric for our early warning signal is based on only classroom outbreaks, you'll see here we show all school-associated outbreaks. So this week, the new outbreaks consisted of 2 outbreaks in elementary schools, 2 in middle schools, and 1 in youth sports. Next slide. Anytime a metric meets the criteria for moderate or high concern, we'll consider enhanced measures that are designed to improve outcomes and move us to a lower level of concern. Since the number of classroom outbreaks again reached the threshold for moderate concern, we continue to work with school partners to implement enhanced safety measures that include strongly recommending masking indoors for staff and students starting next week, improving ventilation where possible at school sites, monitoring students, teachers, and staff for symptoms, recommending weekly testing of unvaccinated individuals, conducting response testing, which is initiated when symptoms and/or exposures are identified, and promoting the proper isolation of cases. We also are recommending that there be weekly testing of all unvaccinated individuals when group contact tracing is being used, and obviously reminding folks that they need to report all cases and outbreaks among staff and students to public health. Although the number of classroom outbreaks, sort of just is over the line to trigger a moderate concern level, our school indicators continue to suggest that school-based strategies have helped to keep transmission and cases in schools very low. Later in the briefing, I'll share updates to the school-based strategies, but first I want to finish with the post-surge response plan update. Next slide, we'll take a look at the remainder of our early alert signals, starting with the community, our community-wide early alert signals. And so one of them, of course, is monitoring the presence of new variants of concern that can threaten our recovery. This slide displays the latest sequencing results through the week that ended February 19th. There are no new variants of concern that were circulating in LA County. Omicron remains the predominant variant, accounting for 100% of all cases, with sequence specimens that were collected in the week that ended February 19th. Among the 4 Omicron sublineages that have been identified, the BA.1.1 lineage, which is a descendant of BA.1, remains the primary Omicron subvariant in LA County. We do continue to closely follow the BA.2 sublineage, which is shown here in red, because it's been shown to be 30% more infectious than BA.1. Since first identified in LA County, BA.2 has accounted for 231 sequenced Omicron cases detected in LA County. While BA.2 is slowly increasing in the county, it still makes up a very small proportion of all sequence cases, accounting for just under 5% of sequence samples for the week ending February 19th. We will continue to track BA.2 along with other variants of concern as part of this early alert dashboard. Next slide. We also are monitoring the 7-day average percent of emergency department encounters that are classified as COVID-related. The 7-day average has been trending down since the year's peak near the start of the year, and it's currently at 4.3%, which qualifies this as an area of low concern. So there are no enhanced mitigation measures warranted at this time. The next slide. Another community-wide early alert signal is the 7-day crude case rate in the lowest income areas in our county. And those are defined as areas where 30% or more of the households are living at or below the federal poverty line. This measure helps ensure that we're protecting those living in communities that have experienced disproportionate risk associated with elevated rates of illness and death from COVID-19. Our latest 7-day average for the lowest income areas is 51 cases per 100,000 population, and that falls well below the trigger for medium concern, which would be 100 to 200 cases per 100,000 residents. Thus, at this time, there's no additional or enhanced community prevention measures needed in response to this alert. Next slide. Of the 4 sectors monitored with early alert signals, we've already reviewed the signal for K-12 schools. And as I noted, the signals for the other 3 sectors did not trigger elevated concerns. This slide shows the trend line of worksite clusters reported from January 1st through March 9th, and that pink line represents new worksite cluster reports. As you can see, the numbers declined dramatically since our peak in January 14th, where we had over 1,900 new worksite clusters reported in 7 days. For the week ending March 8th, there were 30 new worksite cluster reports, which again, well below the threshold for moderate concern, which is 100 to 300 new worksite cluster reports. Given the large number of work sites across the county and the risk for COVID spread at many of these sites, this is very encouraging, and we are hoping that businesses will continue to implement sensible safety precautions that keep their workers and customers safe. Next slide. The last 2 sector-specific early alert signals track outbreaks at skilled nursing facilities and among people experiencing homelessness. For the latest 7-day report ending March 8th, there were 4 new outbreaks opened in skilled nursing facilities and 8 new outbreaks opened at sites serving people experiencing homelessness. With the low numbers of new outbreaks, neither of these sectors triggered concerns. Next slide. The third component of the post-surge plan for LA County describes preparedness efforts to ensure readiness for responding to possible future surges. a variant that might spread more easily, cause more severe illness, or evade vaccine protection, or other challenges. Our preparedness plan, as we noted last week, has 5 focus areas: outbreak management, testing, surveillance, vaccinations, and therapeutics. And next week, we'll actually unveil a dashboard for preparedness activities as well. But today, I'll focus on 2 areas where our efforts are aimed at ensuring dissemination of up-to-date, clear, and reliable information, and assuring easy access to life-saving medical resources, vaccinations, and therapeutics. We can go on to the next slide. As we frequently discussed, vaccines continue to be the most powerful tool for preventing COVID-19 related illness, hospitalizations, and deaths. This slide shows the 7-day adjusted case and hospitalization rates for February 19th through the 25th for people 5 and older by vaccination status. Rates for unvaccinated people are shown in purple. Rates for fully vaccinated but not boosted people are shown in orange. And rates for people who are fully vaccinated and boosted are shown in blue. The slide clearly shows that while COVID-19 vaccines are not 100% effective, they remain effective in preventing infection and are extremely effective in preventing hospitalizations. We see substantial reductions in cases and hospitalizations among fully vaccinated individuals, and even more significant reductions for people who are vaccinated and boosted. For instance, unvaccinated people were about 4 times more likely to be hospitalized for COVID-19 compared to those who were fully vaccinated but not boosted. When adding a booster dose, protection increased significantly. Those who were vaccinated and boosted were 9 times less likely to be hospitalized than people who were unvaccinated. The evidence remains compelling that reducing community transmission, hospitalizations, and deaths, and preventing, therefore, strain on our healthcare system is best accomplished if more residents are vaccinated and boosted. Next slide. Although there's conclusive data supporting the effectiveness and importance of vaccinations, there are about 1.7 million residents who haven't yet received their first dose, and about 2.7 million booster dose eligible residents who aren't benefiting from the extra protection of a booster dose. Given the importance of the booster dose, it's disheartening to see the drop-off in booster coverage rates. There are gaps across all age groups, even amongst our highly vaccinated 65 and older population, where only 63% are fully vaccinated and boosted. Given their elevated risk for severe illness, hospitalization, and death, it's important to remain focused on increasing vaccine awareness, knowledge, confidence, and access for all residents, especially our older adult residents. Next slide. One possible explanation for the low numbers of eligible boosted individuals may be related to the many misperceptions that residents have about the booster doses. Because being fully vaccinated doesn't include having received a booster dose once eligible, there are many individuals that are assuming that as long as you receive the 2 vaccine doses, you don't need a booster. Unfortunately, because vaccine effectiveness for the approved COVID vaccines has been shown to wane over time, a booster dose does offer the best protection, particularly against severe illness, hospitalization, and death. Another common misperception is that if we need boosters, this must mean that the vaccines don't work, so why bother? This really isn't the case. The vaccines are very effective, and for the first few months after being fully vaccinated, the data shows that the protection remains very high. However, since the data also shows that protection fades over time, the booster dose extends the protection by fortifying your immune response to fend off the COVID virus. Some people may also think that being infected with COVID after they've been vaccinated really would give them the same protection as a booster. And getting infected does provide immunity against future infections. But that protection also fades over time. And as we've learned, it may not offer ample protection against different variants. Recent data showed that immunity from a past infection with the Delta variant didn't necessarily protect from getting infected with Omicron. Because the immunity offered by a previous infection wanes, getting a booster dose is still a sensible step to take to maximize your protection. Another myth that we've heard is that the booster doses can make you sick with COVID-19. As with the initial series, it's not possible to get COVID-19 from the booster or the vaccines, because none of the vaccines or the boosters that are used in the United States contain the live virus that causes COVID-19. You certainly can experience side effects from the vaccine, but these are mild. They're not a result of being ill from the virus, and they are a result of the activation of your immune system. And finally, there are some people that think that the booster doses are recommended just so drug companies can sell more COVID-19 vaccines. The recommendation to receive a booster dose isn't based on marketing or profits. It's based on science. For COVID-19 and many other vaccines, you do need several doses over time to stay well protected. Hopefully, as more people talk with their providers and trusted community leaders, they'll hear information that dispels some of these misperceptions. I know that there's a lot of information out there about vaccines, and it's difficult to sort through all of the information. I urge people, if you have questions about vaccines or boosters, visit vaccinatelacounty.com or vacunatelosangeles.com, or please call our COVID-19 information line at 833-540-0473. You can call every day between 8 in the morning and 8:30 at night. Next slide. Addressing myths and connecting people with reliable information is one approach we're using to try to increase vaccine uptake, and especially now booster uptake. We're also working to ensure that residents have ready access to vaccinations in convenient nearby locations. As you can see on this map, as of yesterday, there were nearly 2,000 provider sites administering COVID-19 vaccines and booster doses all across LA County. The fixed vaccination sites are noted in yellow and the mobile sites are in blue. Locations include public health clinics, schools, hospitals, churches, pharmacies, and community clinics. We're also working to ensure that there's ample access within communities that are under-resourced and have been hard hit by the pandemic. These areas are shaded in green on this map. At this time, 52% of our fixed vaccination sites are in these high-need areas. Our mobile units are assigned to fill gaps by bringing vaccines to community gathering places in these hard-hit communities, especially where there are fewer fixed sites. And so nearly 77% of the mobile units providing vaccines are in these hard-hit communities. Next slide. Increasing awareness of and access to therapeutics is also a priority focus for the post-surge preparedness plan. While many people with COVID have mild illness and recover at home, there are others who are at higher risk for getting very sick. Those who are at elevated risk for severe COVID-19 infection, hospitalization, or death may be eligible to receive a new batch of therapeutics, which can prevent some negative outcomes. This slide shows the therapeutics that are currently available in LA County. They include 5 treatment options and 1 medication that's used to prevent COVID-19. All of these medications need to be prescribed by a healthcare provider. Some can be taken by mouth and are available from a pharmacy with a prescription. Other therapeutics are given by an injection or an infusion. Therapeutics used for the treatment of COVID-19 must be given within a specified number of days from symptom onset or from the day you get a positive test result, and they work best if they're given early. And with the exception of remdesivir, supplies of all of these therapeutics are now extremely limited. 2 of the treatment options, Paxlovid and molnupiravir, are antiviral medications that are taken by mouth to treat mild to moderate COVID-19. Paxlovid is for people aged 12 and over who weigh at least 88 pounds. Molnupiravir is for adults 18 and over, and it's not recommended for use during pregnancy. It's actually only recommended if other treatment medications are not available. Both of these oral options require a prescription from a healthcare provider. 2 of the medications that are listed here are monoclonal antibodies that are given by IV infusion and allocated to hospitals and clinics. Remdesivir is an antiviral medication that's approved for inpatient and outpatient use amongst adults and children, including those under 12 years of age who weigh at least 3.5 kilograms. There's an ample supply of this therapeutic. This is the only therapeutic that we have plenty of right now. The final medication on this slide, Evusheld, is not used to treat COVID-19, but rather to prevent infection. Evusheld is administered via an injection, and this is available for people who have not been exposed to COVID-19 and can't get a COVID-19 vaccine for medical reasons. It's also recommended for people who may not respond well to a vaccine because they have a weak immune system due to a medical condition or to treatment. Next slide. Part of the preparedness work at hand is to expand our partnerships with physicians and pharmacies. So once there's ample supply of all the therapeutics, there will be a vast network of providers that can provide both information and prescribe COVID-19 therapeutics, particularly in those communities with residents at elevated risk of poor COVID-19 outcomes. Although Paxlovid, Molnupiravir, and Evusheld are in short supply, in some parts of the county, there is low demand for these treatments. To date, Public Health has distributed nearly 70,000 courses of these life-saving medications to providers and facilities, with 64% of the Paxlovid doses, 82% of the Molnupiravir doses, and 67% of Evusheld allocated to providers in the most under-resourced communities. Next slide. We are concerned that residents may be confused about what medications are available and how to access these drugs. Currently, the medications to prevent and treat COVID-19, because most of them are in limited supply, they're intended for people who are elevated risk for severe COVID-19 illness, hospitalization, and death. And all of them need to be prescribed by a healthcare provider. The oral medications that we talked about, Paxlovid and Molnupiravir, those can be given on an outpatient basis just with a prescription. So if you think you may be a candidate for one of these treatments, please ask your provider if you're eligible. If you don't have a provider, request an appointment from a clinic that's part of the network of providers that are offering these therapeutics. You can get a list of these clinics on our Therapeutics website, ph.lacounty.gov/COVID medicines, or on our Spanish language Therapeutics webpage at ph.lacounty.gov COVID medicamentos. If a provider indicates that you're eligible, you can take your prescription to a participating pharmacy, and our website also has a list of all of these pharmacies. I want to note that the federal government announced a test treat program that launched this week, and it allows patients to walk into local pharmacies that have on-site clinics where they can get tested and receive an oral antiviral medication at the same visit at the same location if the on-site healthcare provider agrees that the treatment is indicated. If they've already been tested, residents can just bring a positive test result to the site to receive the medication if, again, the provider that's on-site recommends and prescribes the treatment. At this time, there are 20 CVS clinics with on-site health clinics that are participating in the Test to Treat program in LA County. And these participating sites, you can look on our website today to get a link to them. This program will later be expanded to include additional participating sites. And we're hoping that it'll include other community pharmacies, long-term care pharmacies, and clinical sites in our hardest hit communities. Residents who think they could be a candidate for Evusheld, that's the prevention medication, or the infusion therapeutics should ask their provider if they're eligible, and if so, coordinate their treatment with them. Public Health will also be launching a pilot project later on, shortly, aimed at providing a telehealth option for patients who are unable to access care or are uninsured. Patients testing positive at selected testing sites in underserved communities will be linked to this telehealth option. And again, if eligible and if approved by a provider, they'll be shipped medications at no cost. I do want to note that the medications are free, but we have heard of some instances where the treating facility may charge for administering the drug. So individuals, please confirm any costs ahead of time with a provider or facility or your insurance provider to make sure that you personally don't get a charge. Residents who want to learn if they're eligible for treatment, access to these medicines, or you just have questions on what would be right for you, you should either contact your medical provider, or if you don't have one and you want to contact us, feel free at our information line, 833-540-0473. This call center is a free resource where residents can get information about the therapeutics, but also help accessing them. Of course, as I noted, you can also visit our website. Next slide. Before closing, there are a couple of updates that I want to share, starting with schools. Since the state issued their new guidance on K-12 schools yesterday, I first want to start and share the update on the LA County TK through grade 12 school and child care isolation and quarantine guidance that will be posted tomorrow. As you know, starting March 12th, the universal indoor masking requirement for TK through grade 12 schools will be lifted. Masking in schools has helped to protect children, teachers, and staff from COVID-19. It's helped to reduce outbreaks and limit the number of school closures and other disruptions of learning. So although indoor masking will no longer be required until transmission is lower, both the state and us here at the Department of Public Health are strongly recommending indoor masking for students, children, teachers, and staff, regardless of vaccination status. School districts in LA County can continue to require masking at schools and during school activities, along with any other appropriate safety protections for their school community. And given the strong recommendation for indoor masking to continue and the reality that there may be many in a school community at elevated risk, there are certain to be schools and districts that will continue their indoor masking protocols until transmission is lower. At other schools where masking becomes optional, we do ask that information about the importance of masking is shared with all members of the school community and that the schools support all those teachers, staff, and students who want to wear a mask. The state is also changing the isolation and quarantine requirements for TK through grade 12 schools, and we will align with those changes in LA County. Schools must continue to require that COVID-19 cases isolate, and a negative test result is required if they want to exit after day 5. Schools continue to have 2 options for managing student exposures while at school. Group contact tracing is recommended when there are exposures in a shared indoor airspace at school, such as a classroom, locker room, or shared transportation. With this approach, schools notify groups of exposed students, such as classmates, teammates, or cohorts, rather than conduct contact tracing to identify individual close contacts. Students in this identified group may remain in school during the quarantine period, provided they have no symptoms. It is now strongly recommended and not required that all those in the exposed group be tested at day 3 to 5 and wear a well-fitted mask through day 10 after exposure. Schools can also opt for individual contact tracing, with that option for modified quarantine for those students who are unvaccinated and had a mask-to-mask exposure. Unless there is a verified mask-to-mask exposure, under this option, students would remain home for 5 days if they're unvaccinated, and have an option to return to school on the 6th day, provided they test negative and have no symptoms. Students returning should wear a well-fitted mask through day 10 of exposure, but similar to the guidance for those participating in group contact tracing, that is now a strong recommendation and not a requirement on the masking. And I want to note that we'll be tracking this really carefully. Obviously, we don't want to inadvertently be aligning with guidance that increases spread of COVID at any of our schools. I do also want to note that during an outbreak at a school or at any other site, the public health team may require more stringent safety measures to stop transmission. And that includes implementing masking requirements, testing of all exposed individuals, and or extending quarantine and isolation periods during the investigation period. And all of our schools, many of our schools have already aware of this because when they've had outbreaks, they've experienced this. Next slide. The second update is about determining how to navigate during this post-surge period. While we're all relieved to be out of our winter surge and to be considered at low community risk by the CDC, there are many in our communities that remain vulnerable given the substantial amount of community transmission. Because of this elevated risk, we're continuing a variety of community prevention strategies that make it easy for individuals to get vaccinated and boosted and to get therapeutics. And this is why indoor masking in public spaces is still strongly recommended. We're also encouraging residents to consider their personal and family's risk when making decisions about precautions, such as masking, gathering, getting tested, and getting vaccinated or boosted. One's personal risk is determined by a variety of factors, and the following are characteristics that can put you at higher risk. If you or someone in your household is not fully vaccinated or boosted, if you or your household members have a chronic condition, including diabetes, high blood pressure, or you're immunocompromised, If you are, or you live with someone, or you care for someone who is 65 and older or too young to be vaccinated and boosted. If you or your household members are in close contact with people at work, school, or another community setting where people are unmasked, unvaccinated, or may be infected with COVID. And if transmission in LA County is at a substantial or high level, that too puts you at higher risk. Those with more risk factors need to take more precautions. For instance, if you have higher levels of personal risk, you should consider always wearing a mask in an indoor public settings. You may want to consider avoiding non-essential indoor gatherings, especially if you don't know others' vaccination status. You might consider getting tested before and after gatherings. And obviously, we would urge you to get vaccinated or boosted if you haven't already done so. In closing, the precautions that we're recommending for persons who are at higher risk or who live with people at higher risk or who care for people at higher risk do offer additional protections against COVID-19. However, anyone can choose to use these or other protections to protect themselves and others, since most of us want to avoid getting infected or reinfected. I hope that folks will take a moment to assess their risk and consider which precautions might be the best options for them, their family members, and other people in their communities or in their work sites. Thank you, and I'm now available to take your questions.
Thank you so much, Dr. Ferrer. Our first question comes from Ron Lynn from the LA Times. Ron, you're unmuted. Go ahead.
Hi, Dr. Ferrer. Thanks so much for taking our questions. Today, it's about COVID versus the flu, pediatric COVID deaths, and Deltacron, this hybrid of Delta and Omicron. So first, you've shown data before showing that during past surges, about 5% of cases were hospitalized, but during Omicron, 1% of cases ended up being hospitalized, a lowering of any particular person's chances of getting severely ill if they're infected. There was some chatter today following a Financial Times analysis suggesting that while overall winter deaths in England and Wales for respiratory illness, including COVID, are still 50% higher than in a pre-pandemic year, the infection fatality rate for COVID is now about the same or a little less than the flu. I know England is different than in LA, but do you expect there could be a time when COVID becomes, quote unquote, only as deadly as the flu? And are we there yet? Second, there was a lot of chatter earlier in the Omicron pandemic regarding coronavirus positive hospitalizations and whether they were for COVID or happened to be patients with COVID. Regarding the 10 pediatric deaths, I think so far reported in LA County due to COVID, do we know whether they were all for COVID or were some of them with COVID? And then finally, on 60 Minutes on Sunday, CDC Director Dr. Rochelle Walensky made a reference to something called Deltacron, said to be a genetic hybrid of the Delta and Omicron variants, which the news report didn't seem like a big deal. And this week, the state epidemiologist, Dr. Erica Pond, mentioned at least one case of Deltacron in California, but also said there's little to suggest it's something to be worried about. Have you seen Deltacron in LA County, and is it something to be worried about? Thank you very much.
Thanks, Ron. Let me just start with the last one. We have not seen Deltacron in LA County. Obviously, we're tracking for any alterations, subvariant types, as well as this, but we haven't seen it. Is it something to worry about? I mean, all variants that get classified as a variant of concern are something to worry about, but we don't have any evidence yet that this is circulating widely or in even in small numbers to know enough about what the implications might be. Big issues with these variants is will our vaccines provide protection? And again, with such small numbers, it's very hard to actually assess that. In terms of our pediatric patients, a good question with COVID. I'm assuming that because you're asking about pediatric deaths, that all of these children, had COVID. But what they were hospitalized for is a good question. I can't answer that. We could try to get back to you on that. I do know that most of these children had underlying health conditions. So I think it's a good question, appropriate question to ask. I just don't have the answer on what was the reason why they were hospitalized in the first place. I do want to note it's often tough to actually just put them in one or two categories, like either they're, hospitalized for, or they're hospitalized with COVID. Sometimes people might be hospitalized with COVID, but then because of underlying health conditions or just the trajectory of the illness, they end up staying in the hospital for COVID. So I do want to note that it may sometimes require us going and looking at medical records to actually make that assessment. And in terms of the first question about, is COVID now just as deadly as the flu? Well, up till now, COVID here has had a much higher mortality rate, cumulative mortality rate. You're right to note that with new therapeutics, with more people vaccinated and the vaccines remaining effective against the most serious and severe illnesses and deaths, it is very likely that in the future, our hope would be that COVID is no longer as deadly as it is now. It'd be nice if it was even less deadly than the flu, but we're not there yet, and it really depends again on making sure that we get a lot of people vaccinated and boosted, and because we know that's helping, and we also continue to get more capacity to distribute life-saving therapeutics. Because I think, again, that's going to make a huge difference in our ability to drive down the fatality rates. So, and that would be good news for all of us. So I think I got to all of yours, and we can go on to the next question.
Our next question comes from Jackie Fortier from KPCC. Jackie, you're unmuted. Go ahead.
Hi there. I was curious if we know if the antiviral pills, since they disrupt the virus's ability to replicate, if they can keep people who get them as treatments from getting long COVID later on. And then separately, I might be a little confused, but could you please explain how the pilot telehealth program will help people who are homebound get access to those treatments? Thank you.
Oh, sure. Sure. In terms of long COVID, I don't know if we have the data on the treatment. We'd have to get back to you, Jackie. Somebody can go here and certainly look through the literature and see what studies have been done. Many of them are relatively new treatments, but it is intriguing to think, and certainly, we've had some indications, for example, that people vaccinated and boosted might be less likely to get long COVID as well. So I think it's intriguing. I think it's completely possible based on the science. I don't know whether there's enough evidence yet to know whether those treatments will go ahead and prevent long COVID. I think there's a lot we don't know about long COVID, and that makes it difficult to answer all of these questions as well. In terms of the pilot that we're planning, one of the issues that we've noted is, how quickly you need to be able to get that prescription, particularly for the oral therapeutics, for them to be effective. In other words, they work best the earlier you get them after you've had a diagnosis, and they actually aren't meant for people who are seriously ill. So Paxlovid, which is what everybody really wants, will work best if there's very little time between the time you test, the time you get an assessment by a provider, because you do need an assessment to determine whether or not this is the right medication for you, and then the time you get the medicine. So if that really required you to go to 3 different places, that would be asking a lot of people to do very quickly. So test to treat, which is what the federal government proposed, narrowed that down to you can go to one site where you can get tested, you can get someone to do the assessment, and you actually can pick up the medication. And that's ideal. This is similar. This is people go somewhere, they get tested. They sign up at the site where they're getting tested to agree to let us, if they get a positive result, send that to our telehealth clinical team. The telehealth clinical team then, if there's a positive result, has information to contact that patient virtually, so nobody has to go make a visit, contacts that patient, does the assessment on whether this is an appropriate treatment, If the telehealth provider, clinical provider, makes that determination, we then ship the medication to that person so that, again, and that person will get it overnight. So again, you reduce the amount of time it takes and certainly the amount of visits that people have to make to separate places. For some people, 3 visits might not be a big hardship. I think for many people it is. And I think anything we can do to make it a lot easier for people to get access to this, have good information, get access, and then to make it super easy for them to get that medication as quickly as possible, because it works better if you get it early on. So thanks for that, Jackie. We can take the next question.
All right. If there are any other questions, please go ahead and raise your hand, or you can chat me, the host. Excellent. Our next question comes from Ryan Carter from LA Daily News. Ryan, go ahead.
Hi, Dr. Ferrer. Thank you this afternoon. Yeah, I mean, this is perhaps a little maybe off the cuff here, but as we go into the lifting of the school mandate, I'm just kind of curious if how you're feeling about that. I think that sort of the dynamics change week to week to some extent here, and just kind of curious if you have any trepidation going into the lifting, and also whether or not you'll have a sense in the coming weeks of whether it's a success. Like, is there sort of a 2-week, 3-week period where you feel like, okay, you'll start feeling kind of comfortable that that this is going to be okay, that this isn't going to lead to an outsized number of outbreaks or something. Thank you.
Yeah, thanks, Ryan. I think it's a great question, and obviously have concerns. Every time we move from having some safety precautions in place to not having them in place, we worry, and we watch, just like you noted, we watch the data really carefully to see if there are any unintended consequences with the move. Especially in this case, since, as I've noted, 2 things. One is transmission is still substantial here in LA County. It's neither moderate or low, and we are not asking people to not use their masks. So I think, again, I think people hear that we are moving away from requiring masking to, it's fine if you don't wear it. And that's actually not our recommendation at all. It's certainly not our recommendation at schools. Our recommendation and the state's recommendation is that everyone keep those masks on at schools. So I think the trepidation is that people aren't necessarily hearing that message as part of it. It's that, we can go from making it a requirement to just asking people to do the right thing. But the right thing still, while transmission is substantial, is to keep those masks on at schools. So, our hope is that many people will keep those masks on. It offers a layer of protection that we think is still important in schools, especially in our elementary schools where there's so many people not yet vaccinated. And again, community transmission is still at a substantial rate, which means there's just a fair amount of virus still circulating. Once those numbers drop, I think everybody will feel a lot more comfortable not strongly recommending that people keep their masks on and moving to a different guidance that perhaps really emphasizes those at higher risk or living with people at higher risk keep their masks on. And others can feel more secure that the risk is low enough that they don't need to wear their mask indoors. But we're not saying that, and the state's not saying that right now. So we'd like people at schools to keep those masks on for a bit longer. And you're absolutely right. I love the last question is, what are we gonna know about the relaxing of some of the requirements at schools? We certainly have concern as well about relaxing, moving from a requirement to a strong recommendation for those who are at school during their quarantine period. We'd like them to either be masked or tested or both. And we'll be watching carefully. I mean, we'll see really quickly, within a few weeks, we'll see whether or not we have more transmission at schools. And that, we've got a track record, we have a trend line, we've been showing you all along what the patterns look like. And if we start seeing some significant increases in outbreaks, which is transmission that happens at school, we'll have to go back and revisit this guidance, because the last thing anybody wants is more transmission at schools. But thanks for that.
That concludes our question and answer period for today. Any closing remarks, Dr. Ferrer?
No, just thanks a lot, everyone. Appreciate all you're doing and your wise counsel to all of your viewers and your readers. And, you know, if you have other questions, we weren't able to get to them today, please just contact us. Thanks a lot.
Thank you so much for joining us today. Any additional press questions can be directed to our media inbox, media@ph.lacounty.gov. Please stay on board. Our Spanish remarks for just a few minutes. Hi, Monica. Are you there?
Yes, I'm here.
Excellent. All right, I have your slides up. Am I okay to go ahead and start?
Yes.
Wonderful. Good afternoon, everyone. Welcome to the Department of Public Health briefing, the Spanish portion of today. Today is March 10th. We have Monica presenting. Monica, when you are ready.
Thank you so much, Kim. Muy buenas tardes y bienvenidos a la sesión informativa de hoy. Nos complace tener la oportunidad de compartir una actualización del estado de la pandemia y brindar más información sobre nuestro plan posterior a la oleada, así como responder a todas las inquietudes que la comunidad tiene. Hoy compartiremos nuestras métricas sobre casos, hospitalizaciones y muertes. Proporcionaremos nueva información sobre nuestra respuesta posterior a la oleada, incluidos los indicadores de nivel comunitario, señales de alerta temprana y los esfuerzos para estar preparados con las vacunas y los tratamientos disponibles. Daremos una actualización sobre los requisitos de uso de mascarilla, aislamiento y cuarentena en las escuelas y finalmente cerraremos con un recordatorio de considerar nuestro riesgo personal y el riesgo de quienes nos rodean al decidir qué precauciones seguir. First slide, please. La semana pasada revisamos los componentes clave de nuestro plan de respuesta posterior a la oleada y hoy daremos los nuevos indicadores y los correspondientes esfuerzos para mejorarlos. Según la nueva metodología de riesgo de los CDC, el condado de Los Ángeles permaneció en la categoría de nivel comunitario bajo esta semana. Esta es una noticia positiva, ya que indica que continuamos minimizando la presión sobre el sistema de salud, que ha sido uno de nuestros principales objetivos desde el comienzo de la pandemia. Sin embargo, este nivel no significa necesariamente que tengamos una transmisión comunitaria baja o que el COVID-19 represente un riesgo personal bajo. Por lo tanto, mientras trabajamos para proteger nuestro sistema de atención médica, también continuaremos utilizando estrategias comunitarias de prevención que pueden reducir el riesgo para todos nuestros residentes, en particular para aquellos más vulnerables. Y proporcionaremos a nuestros residentes información para ayudarlos a tomar las mejores decisiones para protegerse a sí mismos, a sus familiares y a otros seres queridos y su comunidad en general. Con esto en mente, compartiremos las métricas de la semana pasada. Como verá, hemos seguido viendo caídas sustanciales en los casos reportados y las hospitalizaciones y esta semana y las muertes también han disminuido. Hoy estamos reportando 1.372 nuevos casos. El número promedio de casos nuevos diarios informados durante los últimos 7 días se redujo a un promedio de 1.100 de aproximadamente 1.700 casos durante los 7 días anteriores. Del 3 al 10 de marzo, el conteo de casos acumulados de 7 días disminuyó aproximadamente un 5% por día. Nuestra tasa de casos diarios promedio de 7 días ha disminuido a 11 casos nuevos por cada 100.000 residentes. Nuestra tasa de positividad de la prueba diaria promedio de 7 días también ha disminuido a 0,9%, lo que significa que uno de cada 111 resultados de prueba que nos informaron fue positivo en comparación con uno de cada 4 cerca del comienzo del año. Como se señaló, las hospitalizaciones son un componente clave de las medidas a nivel comunitario de los CDC. En el condado de Los Ángeles, las hospitalizaciones continuaron disminuyendo y hoy informamos de 632 personas están actualmente hospitalizadas con COVID, lo que representa una caída significativa con respecto a la semana pasada. Y nuestras muertes diarias reportadas también disminuyeron esta semana a un promedio de 4 muertes al día, de aproximadamente 55 muertes al día durante las 2 semanas anteriores. Si bien esto es alentador, es desalentador que sigamos perdiendo tantos residentes por el COVID y enviamos nuestras condolencias a todos aquellos que están de luto por sus pérdidas. Next slide, please. Como se discutió la semana pasada, los esfuerzos posteriores a la oleada están siendo guiados por nuestro plan de respuesta que tiene tres componentes principales. Uso de los indicadores que reflejen el riesgo, los cuales están vinculados a las estrategias comunitarias de prevención. Señales de alerta temprana que desencadenan una revisión de los factores que contribuyen y la posible necesidad de realinear las estrategias de prevención. Un plan de preparación posterior a la oleada que nos ayudará a responder adecuadamente a la advertencia de una posible oleada o variante que se podría propagar más fácilmente, causar una enfermedad más grave o evadir la protección de la vacuna. Esta semana y en las próximas compartiremos nueva información sobre cada uno de estos componentes principales, comenzando primero con nuestro nivel de contagio basado en la metodología de riesgo de los CDC actualizada y los indicadores que acompañan estas medidas. Como recordatorio, la nueva metodología del CDC asigna niveles de riesgo basados en una combinación de tres métricas. El primer indicador es la tasa de casos de los últimos 7 días. Al determinar el nivel comunitario, los CDC primero establecen si el contacto tuvo menos o más de 200 casos nuevos por cada 100,000 personas en los últimos 7 días, lo que determina el umbral para los indicadores hospitalarios que se utilizan para asignar el nivel comunitario. A partir de hoy, la tasa de casos del condado de Los Ángeles es de 99 casos nuevos por cada 100,000 habitantes. Los siguientes dos indicadores son métricas hospitalarias que sirven como representación del nivel de congestión en el sistema de salud. El primero de estos indicadores es la tasa acumulada de 7 días de nuevos ingresos hospitalarios por COVID-19, que hoy se sitúa en 7,6 ingresos por 100,000 habitantes. Esto cumple con los criterios de los CDC para el nivel de riesgo de contagio bajo. El segundo de estos indicadores es el promedio de 7 días para la proporción de camas de hospital con personal ocupadas por pacientes con COVID-19. Este es de 4,3% para el condado. Hoy, porcentaje también se encuentra en el nivel bajo. Como se señaló antes, nuestra designación como nivel de riesgo comunitario bajo no significa que haya una tasa de baja transmisión comunitaria ni refleje un riesgo personal. Más bien indica que hemos reducido con éxito la presión sobre nuestro sistema de salud. Next slide, please. Esta diapositiva muestra nuestro progreso en los dos indicadores hospitalarios, admisiones diarias y proporción de camas ocupadas por pacientes con COVID utilizadas para evaluar el nivel de congestión del sistema de salud. Se puede ver que ambos continúan disminuyendo a partir del 8 de marzo. La proporción promedio de 7 días de camas para pacientes hospitalizados ocupadas por pacientes con COVID disminuyó en un 90% desde el pico del aumento y la tasa acumulada de ingresos hospitalarios por COVID en 7 días también disminuyó en un 90% desde su punto más alto. Next slide, please. Si bien es importante evaluar el peso de las enfermedades graves y la presión en los hospitales, también estamos rastreando un conjunto de señales de alerta que permitirán la identificación temprana de problemas que pueden indicar la necesidad de realinear las estrategias para frenar la propagación o contener los brotes. Estamos mirando de cerca 7 señales de alerta temprana que incluyen 3 medidas comunitarias, variantes de preocupación, visitas a emergencias por COVID-19 y tasa bruta acumulada de casos en comunidades de alta pobreza. Las señales también incluyen 4 medidas específicas del sector, que son nuevos brotes en centros de enfermería especializada, en aulas de transición a grado 12, nuevos brotes en lugares con personas sin hogar y en lugares de trabajo. Si 2 o más medidas comunitarias alcanzan el umbral de preocupación moderado o alto, realizaremos una revisión de los factores que contribuyen y consideraremos cambios en nuestras estrategias de prevención comunitaria. Si alguna alerta específica del sector alcanza el umbral de preocupación moderada a alta, implementaremos medidas de mitigación que se adapten a ese entorno en particular. Los resultados más recientes de nuestras señales de alerta temprana se enumeran en esta diapositiva. Como puede ver, para esta semana todas las métricas se consideran de baja preocupación, excepto la cantidad de nuevos brotes en las aulas de transición a grado 12. Como fue el caso de la semana pasada, esto alcanzó el umbral de preocupación moderada con 4 brotes en los salones de clase en el periodo de 7 días del 2 al 8 de marzo. Dado que no revisamos los datos de la mayoría de nuestras señales de alerta temprana la semana pasada, revisaremos brevemente cada uno de estos indicadores hoy, comenzando con la métrica de brote escolar, ya que, como se indicó, alcanzó el umbral de preocupación moderada. En futuros informes solo nos centraremos en las señales de alerta temprana que cumplan con los criterios de preocupación moderada o alta. Next slide, please. Esta diapositiva muestra los brotes en las escuelas y programas de transición a grado 12 en los últimos 7 días, que abarcan desde el comienzo del año escolar hasta el 5 de marzo. Es de destacar que mientras la métrica de brotes escolares para las señales de alerta temprana se basa solo en brotes en el aula, esta línea de tendencia muestra todos los brotes asociados con los planteles. Esto incluye brotes en el aula, más brotes entre deportes juveniles, actividades fuera de la escuela y personal. Esta semana se reportaron 2 nuevos brotes en escuelas primarias, 2 en escuelas secundarias y 1 en deportes juveniles. Next slide, please. Cada vez que una métrica cumple con los criterios de preocupación moderada o alta, consideraremos implementar medidas diseñadas para mejorar los resultados que nos lleven a un nivel de preocupación más bajo. Dada la cantidad de brotes en el aula, alcanzó el umbral de preocupación moderada, trabajaremos con los aliados escolares para continuar implementando medidas de seguridad más robustas. Estos incluyen: es altamente recomendable que los estudiantes y el personal usen mascarillas en interiores, mejorar la ventilación en las escuelas donde sea posible, supervisar a los estudiantes, maestros y personal para detectar síntomas, recomendar pruebas semanales a personas no vacunadas, realizar pruebas de respuesta que se hacen cuando se identifican síntomas o exposiciones, promover el aislamiento adecuado de los casos, implementar pruebas semanales de personas no vacunadas cuando se utiliza el rastreo de contactos grupales, informar a salud pública todos los brotes entre el personal y los estudiantes. Y aunque la cantidad de brotes en las aulas es motivo de preocupación moderada esta semana, en general, nuestros indicadores escolares sugieren que las estrategias han ayudado a mantener bajos los niveles de transmisión y los casos en los centros educativos. Más adelante, en la sesión informativa, compartiremos actualizaciones de estas estrategias basadas en la escuela, pero primero terminaremos dando la actualización del plan de respuesta posterior a la oleada. Next slide, please. Ahora proporcionaremos una breve actualización del estado sobre el resto de nuestras señales de alerta temprana. Comenzaremos con los indicadores de toda la comunidad antes de volver a los restantes indicadores específicos por sector. Dado que todos estos se consideran de baja preocupación, los revisaremos rápidamente. Una de las señales de alerta temprana en toda la comunidad es monitorear variantes para identificar la presencia de nuevas variantes de preocupación que puedan amenazar nuestra recuperación. Esta diapositiva muestra nuestros últimos resultados de la secuencia hasta la semana que terminó el 19 de febrero. No hay nuevas variantes de preocupación que circulen en el condado. Omicron sigue siendo nuestra variante predominante y representa el 100% de todos los casos con muestras secuenciadas recolectadas en la semana que terminó el 19 de febrero. Entre los 4 sublinajes de Omicron que se han identificado, el linaje BA.1.1, un linaje descendiente de BA.1, sigue siendo la principal subvariante de Omicron en el condado. Continuamos siguiendo de cerca el sublinaje BA.2, que se muestra en rojo, que ha demostrado ser un 30% más infeccioso que BA.1. Next slide, please. Como parte del tablero de señales de alerta temprana, también monitoreamos el porcentaje promedio de 7 días de ingresos a emergencias que se clasifican como relacionados con COVID. El promedio de 7 días ha tenido una tendencia a la baja desde el punto más alto de cerca del comienzo del año y actualmente se encuentra en 4,3%, lo que califica a esta como una área de preocupación baja. No se justifican medidas adicionales de mitigación mejoradas en este momento. Next slide, please. La tercera señal de alerta temprana en toda la comunidad es la tasa bruta de casos de 7 días en las áreas de ingresos más bajos de nuestro condado, que se definen como las áreas donde el 30% o más de los hogares viven en la línea federal de pobreza o por debajo de ella. Esta medida ayuda a garantizar que estemos protegiendo a quienes viven en comunidades que han experimentado un riesgo desproporcionado de experimentar tasas elevadas de enfermedad y muerte por COVID-19. Nuestro último promedio de 7 días para las áreas de ingresos más bajas es de 51 casos por cada 100,000 habitantes, que está muy por debajo del umbral de preocupación media de 100 a 200 casos por cada 100,000 habitantes. Por lo tanto, en este momento no se necesitan medidas de prevención comunitaria adicionales. Next slide, please. De los 4 sectores seguidos por el tablero de señales de alerta temprana, ya revisamos el de las escuelas de kinder a grado 12. Como se indicó, las señales de los otros 3 sectores no generaron gran preocupación. Esta diapositiva muestra la línea de tendencia de los brotes en lugares de trabajo informados desde el 1 de enero hasta el 8 de marzo, y la línea rosada representa los nuevos informes de brotes de lugares de trabajo. Este número ha disminuido drásticamente desde nuestro pico del año, el 14 de enero, cuando se informaron casi 1,930 brotes en lugares de trabajo en los últimos 7 días. Para la semana que finalizó el 8 de marzo, hubo 30 nuevos informes de brotes en lugares de trabajo, lo que está muy por debajo del umbral de preocupación moderada de 100 a 300 nuevos informes de brotes en lugares de trabajo. Dada la gran cantidad de entornos laborales y el riesgo de propagación de COVID en estos, es muy alentador y esperamos que las empresas puedan continuar implementando protecciones de seguridad sensatas que mantengan seguros a los trabajadores y clientes. Next slide, please. Las últimas 2 señales de alerta temprana específicas del sector rastrean los brotes en los centros de enfermería especializadas y entre los de personas sin hogar. Para el último periodo de 7 días que finalizó el 8 de marzo, se abrieron 4 nuevos brotes en los centros de enfermería especializada y 8 nuevos brotes en sitios que atienden a las personas sin hogar. Con un bajo número de nuevos brotes, ninguno de estos sectores generó preocupaciones. Next slide, please. El tercer componente del plan posterior a la oleada describe los esfuerzos para prepararnos para responder a futuros picos, una variante que podría propagarse más fácilmente, causar una enfermedad más grave o evadir la protección de la vacuna u otros desafíos. Nuestro plan tiene 5 áreas de enfoque clave: manejo de brotes, pruebas, vigilancia, vacunas y terapias. Hoy nos centraremos en 2 áreas en las que estamos centrando nuestras acciones con el objetivo de garantizar la difusión de información actualizada, clara y confiable, y asegurar un fácil acceso a los recursos médicos que salvan vidas, vacunas y tratamientos. Next slide, please. Como hemos discutido en varias ocasiones, las vacunas continúan siendo nuestra herramienta más poderosa para prevenir enfermedades, hospitalizaciones y muertes relacionadas con COVID. Esta diapositiva muestra las tasas de hospitalización y casos ajustados por edad de 7 días del 19 al 25 de febrero para personas de 5 años y mayores por estado de vacunación. Las tasas de personas no vacunadas se muestran en morado, Las de personas vacunadas por completo pero sin refuerzo están en naranja y las tasas para completamente vacunados y con refuerzo se ven en azul. Esta diapositiva muestra claramente que si bien las vacunas contra el COVID no son 100% efectivas, son muy efectivas para prevenir infecciones y extremadamente efectivas para prevenir hospitalizaciones. Vemos reducciones sustanciales en casos de hospitalizaciones entre personas con todas las vacunas e incluso reducciones más significativas entre quienes están vacunados y reforzados. Por ejemplo, las personas no vacunadas tenían cerca de 4 veces más probabilidades de ser hospitalizadas por COVID en comparación con aquellas que estaban completamente vacunadas pero sin refuerzo. Al agregar una dosis de refuerzo, la protección aumentó significativamente. Aquellos que fueron vacunados y recibieron el refuerzo tenían 9 veces menos chances de ser hospitalizados que las personas que no estaban vacunadas. La evidencia sigue demostrando que reducir la transmisión comunitaria, las hospitalizaciones y las muertes y prevenir la atención en el sistema hospitalario y de atención médica se logra mejor si más residentes se vacunan y reciben el refuerzo. Next slide, please. Aunque hay datos concluyentes que respaldan la eficacia y la importancia de las vacunas, hay alrededor de 1,7 millones de residentes que no han recibido su primera dosis y alrededor de 2,7 millones de personas a quienes les ha llegado la hora de recibir el refuerzo, pero que no se benefician de la protección adicional que ofrece esta dosis. Dada la importancia del refuerzo, es desalentador ver que han bajado las tasas de cobertura de refuerzo. Hay brechas en todos los grupos de edad, incluso entre nuestra población de 65 años o más altamente vacunada, donde solo el 63% está vacunado por completo y ha recibido el refuerzo. Teniendo en cuenta su elevado riesgo de enfermedad grave, hospitalización y muerte, es importante que nos mantengamos enfocados en aumentar la concientización, el conocimiento, la confianza y el acceso a las vacunas para todos los residentes, incluidos los adultos mayores. Next slide, please. Una posible explicación del bajo número de personas que pueden recibir el refuerzo puede estar relacionada con las muchas percepciones erróneas sobre el refuerzo que los residentes puede que tengan. Debido a que estar completamente vacunado no incluye haber recibido dosis de refuerzo una vez se han cumplido el tiempo para recibirlo, muchas personas asumen que siempre que hayan recibido las dos dosis de la vacuna, no necesitan el refuerzo. Desafortunadamente, debido a que se ha demostrado que la efectividad de las vacunas COVID disminuye con el tiempo, una dosis de refuerzo ofrece la mejor protección particularmente contra las enfermedades graves, hospitalización y muerte. Otra percepción errónea es que si necesitamos refuerzos, esto quiere decir que las vacunas no funcionan. Esto no es el caso. Las vacunas son muy efectivas y durante los primeros meses después de haber recibido la vacuna completa, los datos demuestran que la protección sigue siendo alta. Sin embargo, dado que la protección se desvanece con el tiempo, la dosis de refuerzo extiende la protección al fortalecer la respuesta del sistema inmune para defenderse contra el virus. Algunas personas también pueden pensar que infectarse con COVID después de haber sido vacunadas les brinda la misma protección que el refuerzo. La infección brinda inmunidad contra futuras infecciones, pero esa protección también se desvanece con el tiempo y es posible que no ofrezca una amplia protección contra diferentes variantes. Los datos recientes mostraron que la inmunidad de una infección anterior de la variante Delta no protegía necesariamente de las infecciones de Omicron. Debido a que la defensa que ofrece una infección anterior puede variar, recibir una dosis de refuerzo sigue siendo un paso sensato para maximizar su protección. Otro mito que hemos escuchado es que las dosis de refuerzo pueden enfermarlo con COVID-19. Al igual que con la serie inicial, no es posible contraer COVID-19 a través del refuerzo o la vacuna porque ninguna de las vacunas y refuerzos que se usan en los Estados Unidos contienen el virus vivo que causa el COVID-19. Ciertamente puede experimentar efectos secundarios tras recibir la vacuna, pero estos son leves y son el resultado de la activación del sistema inmunológico en el cuerpo. Y finalmente, algunas personas piensan que las dosis de refuerzo se recomiendan solo para que las compañías farmacéuticas puedan vender más vacunas contra el COVID. La recomendación de recibir una dosis de refuerzo no se basa en mercadeo, está basada en la ciencia. La del COVID y muchas otras vacunas necesita que se inocule varias dosis a lo largo del tiempo para que sigan protegiendo. Con suerte, a medida que más personas hablen con sus proveedores y líderes comunitarios de confianza, escucharán información que disipará algunas percepciones erróneas. Sabemos que hay mucha información disponible sobre las vacunas que puede ser difícil de digerir. Si tiene preguntas sobre vacunas o refuerzos, puede visitar vacunatelosangeles.com o llamar a nuestra línea de información sobre COVID al 833-540-0473 de 8 de la mañana a 8 de la noche, que está abierta todos los días. Next slide, please. Abordar los mitos y conectar a las personas con información es una forma de aumentar la aceptación de la vacuna. También estamos trabajando para garantizar que los residentes tengan fácil acceso a las vacunas en lugares cercanos y convenientes. Como puede ver en este mapa, hasta ayer había casi 2,000 sitios de proveedores que administran vacunas y dosis de refuerzo contra COVID-19 en todo el condado de Los Ángeles. Los sitios de vacunación fijos que se indican en amarillo y los sitios móviles se indican en azul. Las ubicaciones incluyen nuestras clínicas de salud pública y los centros de distribución, escuelas, hospitales, farmacias, clínicas comunitarias y lugares para profesar la fe. También estamos trabajando para garantizar que haya un amplio acceso dentro de las comunidades que tienen recursos insuficientes y que han sido duramente golpeadas por la pandemia. Estas áreas están sombreadas en verde en este mapa. En este momento, el 52% de nuestros puestos fijos de vacunación se encuentran en áreas de muchas necesidades. En nuestras unidades móviles llevan la vacuna a los lugares donde se reúne la comunidad, en aquellos sitios donde hay menos puestos fijos. Casi el 77% de nuestras unidades móviles aplican vacunas en comunidades. Next slide, please. El aumento en la concientización y el acceso a los tratamientos de COVID-19 también es un enfoque prioritario del plan de preparación posterior a la oleada. Si bien muchas personas con COVID tienen una afección leve y pueden recuperarse en casa, otras corren un mayor riesgo de enfermarse gravemente. Aquellos que tienen un riesgo elevado de infección grave por COVID-19, hospitalización o muerte pueden recibir medicamentos que pueden evitar resultados negativos. Esta diapositiva muestra los tratamientos que están disponibles en el condado de Los Ángeles. Estos incluyen 5 opciones terapéuticas y un medicamento que se usa para prevenir el COVID. Todos estos medicamentos deben ser recetados por un proveedor de atención médica. Algunos se pueden tomar vía oral y se puede acceder a ellos en las farmacias previa prescripción médica. Otras terapias se administran mediante inyección o infusión. Las terapias utilizadas para el tratamiento de COVID deben administrarse dentro de un número específico de días desde el inicio de los síntomas y funcionan mejor cuando se toman temprano. Con la excepción de remdesivir, los suministros de estas terapias son extremadamente limitados. 2 de las opciones de tratamiento, Paxlovid y Molnupiravir, son medicamentos antivirales que se toman por vía oral para tratar el COVID-19 leve o moderado. Paxlovid es para personas mayores de 12 años que pesan al menos 88 libras. Molnupiravir es para adultos mayores de 18 años. No se recomienda su uso durante el embarazo y solo se aconseja si no hay otros medicamentos disponibles. Ambos requieren una receta de un proveedor de atención médica. 2 de los medicamentos son anticuerpos monoclonales administrados por infusión intravenosa y asignados a hospitales y clínicas. Remdesivir es antiviral que está aprobado para uso en pacientes hospitalizados y ambulatorios adultos y niños, incluidos los menores de 12 años que pesan al menos 3,5 kilogramos. Hay una amplia oferta de este medicamento. La última terapia de esta diapositiva, Evusheld, no se usa para tratar el COVID-19, sino para prevenir infecciones. Evusheld se administra mediante inyección y está disponible para personas mayores de 12 años que pesan al menos 88 libras, que no han estado expuestas al COVID, pero no pueden vacunarse contra COVID por razones médicas. También se recomienda para personas que no pueden responder bien a una vacuna porque tienen un sistema inmune débil debido a una afección o tratamiento médico. Next slide, please. Salud Pública está trabajando para expandir las alianzas con proveedores y farmacias para garantizar una amplia red de abastecedores que puedan brindar información y recetar medicamentos para el COVID, particularmente en aquellas comunidades con residentes que tienen un riesgo elevado de resultados graves por COVID. Como se señaló, Paxlovid, Molnupiravir y Evusheld son escasos y Salud Pública ha distribuido a proveedores y aliados casi 7,000 dosis de estos medicamentos que salvan vidas. Desde que el condado comenzó a recibirlos, el 64% de las dosis de Paxlovid, el 82% de las de Molnupiravir y el 67% de las de Evusheld se han asignado a distribuidores en las comunidades con menos recursos. Next slide, please. Nos preocupa que los residentes puedan estar confundidos acerca de qué medicamentos están disponibles y cómo acceder a ellos. Los medicamentos para prevenir y tratar el COVID-19 son para personas que tienen un riesgo elevado de enfermedad grave, hospitalización y muerte por COVID y deben ser recetados por un proveedor de atención médica, como hemos mencionado. Paxlovid y Molnupiravir son orales y se pueden administrar de forma ambulatoria con receta médica. Si cree que puede ser candidato para uno de estos tratamientos, pregúntele a su proveedor. Si no tiene un médico, solicite una cita en una clínica que sea parte de la red de lugares que ofrecen estas terapias. Puede obtener una lista de esas clínicas en nuestro sitio de internet, que lo ve en la parte inferior de esta diapositiva, o también tenemos una página web con terapias, con toda esta información de tratamientos en español, cuyo enlace también lo ve en esta diapositiva. Si el proveedor indica que usted no reúne las condiciones, puede llevar su receta a una farmacia. Puede visitar la página web para ver la lista de estas farmacias. El gobierno federal también anunció recientemente el programa Prueba para Tratar, que se lanzará esta semana y permitirá a los pacientes ir a las farmacias locales que tienen clínicas en el lugar para hacerse la prueba y recibir un medicamento antiviral oral en la misma visita y en el mismo lugar, siempre y cuando el proveedor de atención médica en el sitio está de acuerdo con que el tratamiento es el indicado. Si se ha hecho la prueba, los residentes también pueden traer su resultado positivo al sitio para recibir el medicamento si el proveedor así lo recomienda y prescribe este tratamiento. En este momento, 20 farmacias de CVS con clínicas de salud en el lugar están participando del programa Prueba para Tratar. Estas se incluirán hoy en nuestro sitio web. Este programa se ampliará posteriormente para incluir más lugares, que pueden ser otras farmacias comunitarias, farmacias de atención a largo plazo y clínicas adicionales. Los residentes que piensen que pueden ser candidatos para Evusheld o la terapia de infusión deberán preguntar a su proveedor si reúnen las condiciones y, de ser así, coordinar su tratamiento con ellos. Salud Pública también lanzará un proyecto piloto destinado a brindar una opción de telesalud para pacientes que no pueden acceder a la atención o no tienen seguro. Los pacientes que den positivos en sitios de pruebas seleccionados en comunidades desatendidas serán vinculados a una opción de telesalud y, si reúnen los requisitos, se les enviarán medicamentos sin costo alguno. Estos medicamentos son gratuitos, pero en algunos casos el centro de tratamiento puede cobrar por administrarlo. Las personas pueden confirmar cualquier costo con el proveedor, el centro o la empresa de seguros. Los residentes que deseen saber si pueden recibir el tratamiento, acceder a estos medicamentos o si tienen preguntas sobre qué es lo adecuado para ellos, deben comunicarse con su proveedor médico o llamar a nuestra línea de información sobre COVID al 833-540-0473 de 8 de la mañana a 8:30 de la noche, abierta todos los días. El centro de llamadas es un recurso gratuito donde los residentes pueden obtener información sobre las terapias disponibles y cómo acceder a ellas. Nuevamente, la información de estas páginas web y nuestro teléfono está al final de esta diapositiva. Next slide, please. Antes de cerrar, un par de actualizaciones, comenzando con las escuelas. Dado que el Estado emitió ayer su nueva orientación sobre las escuelas de kinder a grado 12, compartiremos nueva información sobre la guía para transición a grado 12, las guarderías, el aislamiento y la cuarentena que se publicará mañana. Como saben, a partir del 12 de marzo se eliminará el requisito universal de uso de mascarillas en interiores en los planteles de transición a grado 12. El uso de cubrebocas en las escuelas ha ayudado a proteger del COVID a los niños, los maestros y el personal y ha permitido reducir los brotes y limitar la cantidad de cierres de las escuelas y otras interrupciones al aprendizaje. Por lo tanto, aunque ya no se requiere el uso de tapabocas en los interiores, hasta que la transmisión sea menor, tanto el Estado como nosotros consideramos que es altamente recomendable que los estudiantes, los maestros, el personal usen mascarillas en todas las áreas bajo techo, independiente del estado de vacunación. Los distritos escolares del condado pueden seguir exigiendo el uso de cubrebocas en las escuelas y durante las actividades escolares, junto con otras protecciones de seguridad adecuadas para su comunidad educativa. Y da la fuerte recomendación de continuar con el uso de mascarillas en interiores y la realidad de que puede haber muchos en una comunidad escolar con un riesgo elevado, seguramente habrá planteles y distritos que continúen con sus protocolos de uso de tapabocas en interiores hasta que el contagio sea menor. En otras escuelas donde el cubrebocas será opcional, pedimos que la información sobre la importancia de este se comparta con todos los miembros de la comunidad escolar y que las escuelas apoyen a todos aquellos maestros, personal y estudiantes que quieran usar mascarillas. El Estado también está cambiando los requisitos de aislamiento y cuarentena para las escuelas de transición a grado 12 y el condado de Los Ángeles se alineará con estos cambios. Las escuelas deben seguir requiriendo el aislamiento de casos de COVID y se requerirá una prueba negativa para salir después del día 5. Los planteles continúan teniendo dos opciones para manejar las exposiciones de los estudiantes mientras están en la escuela. Se recomienda el rastreo de contactos grupales cuando hay exposiciones en un espacio interior compartido, como un salón de clases, los vestuarios y el transporte. Con este enfoque, las escuelas notifican a grupos de estudiantes expuestos como compañeros de clase, de equipo, en lugar de realizar un seguimiento de contactos para identificar contactos cercanos individuales. Los estudiantes de este grupo pueden permanecer en la escuela durante el periodo de cuarentena siempre que no tengan síntomas. Ahora es altamente recomendable, pero no obligatorio, que todos los miembros del grupo expuestos se hagan la prueba entre los días 3 al 5 y usen una mascarilla bien ajustada hasta el día 10 después de la exposición. Las escuelas también pueden optar por el rastreo de contactos individuales con una opción de cuarentena modificada para aquellos estudiantes que no están vacunados y que tuvieron una exposición mascarilla a mascarilla verificada. Según esa opción, los estudiantes deben permanecer en casa durante 5 días con la opción de regresar a la escuela el 6º día, siempre que la prueba sea negativa y no tengan síntomas. Los estudiantes que regresen deben usar un cubrebocas bien ajustado hasta el día 10 de la exposición. Cabe destacar que durante un brote en una escuela o cualquier otro sitio, el equipo de salud pública puede requerir medidas de seguridad más estrictas para detener la propagación, incluida la implementación de requisitos de uso de mascarillas, pruebas a todas las personas expuestas y o la extensión de los periodos de cuarentena y aislamiento durante la investigación. Next slide, please. La segunda actualización se trata de determinar cómo navegar durante este periodo posterior a la oleada. Si bien nos sentimos aliviados de estar fuera de nuestro aumento invernal y de que los CDC nos consideren en bajo riesgo comunitario, hay muchas personas en nuestras comunidades que siguen siendo vulnerables dada la cantidad sustancial de propagación comunitaria. Debido a este riesgo elevado, continuamos implementando una variedad de estrategias de prevención que facilitan que las personas se vacunen y reciban el refuerzo y obtengan terapias y el por qué aún se recomienda el uso de mascarillas en el interior de espacios públicos. También alentamos a los residentes a que consideren el riesgo personal y el de su familia al tomar decisiones sobre precauciones de usar mascarilla, reunirse, hacerse la prueba y vacunarse o recibir el refuerzo. El riesgo personal de cada individuo está determinado por una variedad de factores y las siguientes son características que pueden exponer a este individuo en un mayor riesgo. Si usted o los miembros de su hogar no están completamente vacunados o con el refuerzo. Si usted o los miembros de su hogar tienen una enfermedad crónica como diabetes, presión arterial alta o tienen un sistema inmune débil. Si vive o cuida a alguien de 65 años o más o vive o cuida a un niño que es demasiado joven para vacunarse y recibir el refuerzo. Si usted o los miembros de su hogar están en contacto cercano con personas en el trabajo, la escuela u otro entorno comunitario y no usan cubrebocas, no están vacunados o pueden estar infectados con COVID-19, y si el riesgo de propagación comunitaria en el condado es de nivel sustancial a alto. Aquellos con más factores de riesgo deben tomar precauciones adicionales. Por ejemplo, si tienen niveles más altos de riesgo personal, debe considerar lo siguiente: usar siempre una mascarilla en lugares públicos cerrados. Evitar reuniones no esenciales en interiores, especialmente si no conoce el estado de vacunación de los demás. Hacerse la prueba antes y después de las reuniones, vacunarse o recibir el refuerzo si aún no lo ha hecho. Para terminar, las precauciones que recomendamos que las personas en mayor riesgo tomen les ofrecen la mejor oportunidad para protegerse contra el COVID. Sin embargo, cualquiera puede optar por usar estas u otras precauciones para protegerse a sí mismo y a los demás. Esperamos que la gente se tome un momento para evaluar su riesgo y considerar qué precauciones serán las apropiadas para ellos, sus familiares y otros seres queridos. Muchas gracias y nos veremos en la próxima ocasión.
Thank you so much, Monica, and thank you to everyone who joined us today. As a reminder, additional press questions can be directed to our media inbox at media@ph.lacounty.gov. Thank you once again for joining us, and we will see you next week.